Good morning, good evening, hello everywhere. Welcome to the Patients Engaged podcast series, Lived and Leading, Voices for Better Healthcare, where we feature persons with lived experience of a condition or a disability and how they are channeling their learnings into improving healthcare. They could be providing peer support or they could be advocating for changes in the system. Quick recap, Patients Engage is a platform that empowers people with chronic conditions and disabilities to engage better with their health and make informed decisions. We also advocate for more meaningful involvement of people living with long-term conditions in health system decision-making. I'm Aparna Mittal from Patients Engage, and today I'm speaking with Tina Aswani-Omprakash and Madhura Balasubramaniam, both of whom live with IBD, inflammatory bowel disease, and are co-founders of the South Asia IBD Alliance. They live in the US and India respectively, and both bring different experiences and skill sets to their work in patient engagement, community building, and advocacy. So during the course of this conversation, we will refer to inflammatory bowel disease as IBD and to the South Asia IBD Alliance as SAIA, and I think there may be reference to IBDCs as well, which is what the community is called. So for those of you who are not clear, inflammatory bowel disease or IBD is a group of inflammatory conditions of the colon and small intestine. The common types of IBD are Crohn's disease and ulcerative colitis, but there are a few others. South Asians and Indians face unique challenges in managing IBD, including low disease awareness, diagnostic difficulties, limited access to specialized care, and high costs associated with treatment. Additionally, cultural factors also hinder treatment access, adherence, and acceptance of medical intervention. So in this conversation with Tina and Madhura, we will hear of their journey from diagnosis to advocacy, the unique challenges of South Asian IBD patients, as well as some of the initiatives that SAIA has undertaken to build an informed community of persons living with IBD and how they address some of the gaps in access to care. So welcome to the show, Tina and Madhura. Thank you for joining us today.
Thanks for having us.
Thank you for having us today, Aparna.
Thank you. Thank you. So if you can introduce yourselves in a couple of sentences, who you are beyond your diagnosis of IBD, right? So maybe Tina, you can start.
Hi, everyone. My name is Tina Aswani-Omprakash. Thank you, Aparna, for having us here today. I'm thrilled for us to represent SAIA. I am one of the co-founders and the CEO of SAIA, and some of the work that we do is very important. We'll be going into that today, but beyond IBD, I am a wife, a sister, a daughter, and I am a disability activist, and I am thrilled to be helping to represent the community today.
Thank you. Thank you, Tina. Madhura?
Thanks, Aparna. And I will just add to Tina's introduction. She's also an amazing friend and an amazing support system for lots of us living with IBD. I'm Madhura. I'm a Crohn's disease patient as well, and one of the co-founders of SAIA. And beyond IBD, I'm a PhD student. I'm getting my PhD in international relations, and I love taking photographs of dogs, and I'm now learning how to bake. Some of which is good, some of which is disastrous. So that's what I do beyond my IBD and beyond my IBD work.
Excellent, excellent. So if you can both kind of, and I know, you'll have both had long and eventful journeys, but if you can, in a very short kind of synopsis, recap your journey from symptoms to diagnosis and treatment management. And again, maybe Tina, you can start.
Sure. Thanks, Madhura, for those kind words. Likewise for you, being an amazing friend and colleague. As far as my journey goes, it's been a pretty long and windy, complicated history of Crohn's disease. I was originally diagnosed with ulcerative colitis, which is another form of IBD. And we'll be talking about a lot of this today. But I went through a lot of surgeries because there were not enough medication options and I wasn't responding to the existing medication options. I do have a family history. I know they say IBD is a newer disease in the East. But in some ways, I beg to differ. My father and aunt died of IBD that turned into colorectal cancer because after 8 to 10 years of having IBD, if it's not managed fully, pockets of your colon and rectum can develop cancer. So that's a point I wanted to emphasize today. And in addition to that, their aunt also back in Karachi before partition passed away from something that looked very similar to IBD/colorectal cancer. She was bleeding significantly and died from that in her 30s.
Wow. Sorry about that. Yeah. Okay. So in terms of that's kind of your background, do you want to talk a little bit about, I know you said, are there any highlights on your long and winding journey that you want?
Yeah, absolutely. So I had a J pouch done, which is, when you get your colon and rectum removed, they fashion a small J-shaped pouch out of your small intestine, connect it to the little sliver that's left of your rectum so that you can defecate, go to the bathroom normally. But it happens to be about 6 to 8 times a day rather than maybe once or twice a day. So I had that done. It did not work out because it actually turned out to be Crohn's. Crohn's can affect you anywhere from the mouth to the anus, whereas ulcerative colitis can affect you from the colon and rectum. So because it was Crohn's disease, the disease started hitting my J pouch. I had a J pouch for about 6 years, but that was a very, very difficult time for me. And I did end up having to have the J pouch removed. And I had multiple bouts of getting an ostomy back, trying the J pouch out, et cetera, et cetera. And, there's just so much stigma in our community around having an ostomy. And I'm sure we'll be talking about that a bit today too, that my family really wanted me to maintain the J pouch for marriageability purposes, reproductive purpose, all of the above. And so I tried really hard for those 6 years, and I developed something called fistula, and I had several of them. Fistulas are like tunnels that form from your intestine. You can develop inflammation and then ulceration, and then that ulceration can break through the intestine and form these tunnels into other organs. Unfortunately, I developed severe rectovaginal fistulae, which was very traumatic on me, and perianal fistulae, which broke out onto my bottom, out onto the skin. This led to sepsis and several other many infections. Had a whole host of skin and joint, eye manifestations, liver manifestations, UTIs galore due to the honestly related to the fistulae. It was very harrowing for me. I had just gotten married, and it was one of those things where I was like, I can't continue to do this. Like, I was so much more comfortable with an ostomy, and it really gave me my life back. So about 10 years ago, I had all of that taken care of. It was probably my most traumatic set of surgeries at the Mayo Clinic here in the United States. Very difficult time. And then I joined a clinical trial after that because there were honestly no drugs. Had there been drugs that could treat my medications, I could treat my condition appropriately, I probably wouldn't have gone through all this. These severe complications manifested because the medications had not caught up yet with the disease. Now, in the last 3 years, at least in the United States, there's been a launch of several new drugs, different mechanisms of action. We're seeing better outcomes for patients. That's exactly what we're hoping for, is effective medication uptake to prevent severe complications and surgery in patients who don't deserve to go through that.
Absolutely. Thank you. Madhura, do you want to kind of give a quick recap of your journey as well?
Sure, happy to. So in my case, I was diagnosed in 2019, but I've been living with symptoms for as long as I can remember, at least from the age of 4, though my mother thinks that, I've had symptoms maybe even as young as 6 months of age. So I would live with multiple bouts of diarrhea and vomiting, and and this was the only life I knew, right? Like I actually don't know a life before where my bowels were normal, so to speak. So at age 10, I underwent some of my first set of investigations, and I was diagnosed with celiac disease temporarily. They weren't sure what was causing the kind of damage that they were seeing in my upper GI endoscopy, but because it looked a little bit like celiac disease, they decided that this was celiac disease, and I was treated with a gluten-free diet. But at that time, I was around 20 kilos and maybe 120 centimeters, so way below the weight and height requirements. This is a condition called failure to thrive. This happens when children have difficulties with digestion and absorption, and it prevents you from hitting your regular growth and development milestones. So going on a gluten-free diet helped. Definitely, I was able to catch up to some extent, but I still suffered from significant malnutrition all through my teens and early 20s. And in 2019, I had just started my first job out of my master's degree. I was a field research person. I was doing a lot of qualitative research, traveling around the country, and all the while living with severe diarrhea, vomiting, weight loss, incontinence, you name it, thinking that, maybe I'm just getting gluten or drinking bad water or eating something that I shouldn't be eating. And it was at that time I was finally given a colonoscopy. Up till that point, I never had a colonoscopy, and the colonoscopy found fairly extensive bowel involvement. So I was diagnosed with Crohn's disease, both in the small and in the large bowel. Unfortunately, since I had gone untreated for so long, when they actually managed to diagnose the IBD, I deteriorated very quickly. So I dropped down to something like 34 kilos, and I was asked if I would like to have a feeding tube, which is fairly rare in India. Most of us aren't presented this option, especially those of us who have IBD. But I did agree to have a percutaneous endoscopic gastroscopy. So it's a small feeding tube that's placed in your stomach. And that really helped to address some of the malnutrition issues that I had. And it also gave me the confidence to really take charge of my disease and take charge of my treatment. And of course, I went through a bunch of complications, including a fistula, several bowel obstructions, before I got onto a biologic therapy and got onto an optimized dosing of the biologic therapy. While extremely expensive, still less expensive than the cost of disability for me. So that's been my IBD journey. While touch wood, thankfully, I'm in remission, I do still live with several issues because of the long-standing damage that has already happened in terms of digestion absorption, as well as some skin-related manifestations that aren't fully treated right now. But again, very grateful for the opportunity to have quality of life and ensure, like Tina said, that other patients don't experience such long delays to diagnosis and treatment.
Right, right. And I think that's like a perfect segue to the next question as to, what brought the two of you together and what led to the formation of SAIA. What was the idea behind it? And if you can also, for the audience, let us know the objective behind it.
Yeah, that's a great question, Aparna. So about 4.5 years ago, so early 2021, I had been a part of other Facebook groups. Others have been doing great work as well. But I recognized that there was a real need that, we needed to do something in terms of helping South Asians who live with IBD, that there's real stigma towards not just the disease, but towards taking medication for this disease. So one thing I want to explain is oftentimes IBD is sort of equated with IBS, and it's often mixed up. And like even to the extent where we've tried to publish articles in India, and the IBD acronym is changed to IBDS because they think we've made a mistake. That's how significant, the misconception is that IBD is IBS. And not to poo-poo on IBS.
Just to interrupt you, I think for the audience, IBS is irritable bowel syndrome, whereas IBD is inflammatory bowel disease. So that, if there are people who don't really know the two, then. Yeah, go ahead.
Exactly. And to explain the difference, not to poo-poo IBS because I have IBS too, but IBS can really be it's a syndrome, like you mentioned, irritable bowel syndrome, where your bowels do become irritated to an extent. It could be diet, lifestyle, stress related. And it is a chronic condition too. And you can develop pretty severe constipation from it, like I have, and pretty severe diarrhea from it, or you can go back and forth, or it could be like a
Right.
complete mix of the two. So it is a pretty debilitating condition of its own right. But IBD is a little bit different in the sense that it is an immune-mediated inflammatory disorder, an IMID, an autoimmune condition where your own cells are attacking the gut, the lining of the gut, and deteriorating that lining such that you can't digest any food, you're bleeding, you're having significant abdominal pain, and like Madhura described, malnutrition as a result. And that malnutrition can be severe. Like she said, she dropped down to 34 kgs. I dropped down to 38 kgs with a height of 5'6". So that should tell you like how significant the malnutrition can be. So IBD is different. And a lot of people can treat IBS without medications. Some of us do need medications for IBS, but there are significant immunosuppressive medications for IBD. And why do we suppress the immune system? So that the immune system does not attack the gut. It's
Right.
because it's that severe. So going to the formation of SAIA, while I had seen other Facebook groups, I had also developed a presence through my Own Your Crohn's platform and Own Your Crohn's blog, since 2018. And one of the earliest things I noted when I came out with my disease, because it was a coming out process in our culture. Even though I live in New York, it was a coming out process. It's still very stigmatized amongst South Asian Americans.
Right.
I realized because of the volume of patients from different countries, including South Asia, but beyond South Asia too, Latin America, Africa, Middle East, East Asia, all over, you name it, because of the volume of patients reaching out saying, oh my God, there's a cultural phenomenon going on here. And there's cultural phenomenons within even India itself, and we can talk
Right.
about that.
Right.
But because of that, I realized, wow, this is way beyond anything I'd ever imagined. And this is like opening a Pandora's box. I came across Madhura, even Sharon, who's a part of our team out of the UK. I came across others, and Madhura and Sharon really wanted to join me in starting this community. And so we formed the IBD Desis community in January 2021. Very quickly, we realized, okay, we need to take on other folks. We need to build a social media platform. This is a lot bigger than we realized within 3 months.
Right.
And then within 3 months of that, there were multiple doctors reaching out saying, hey, how do we partner? And doctors I've already been working with saying, this is amazing. Like, can we do something together? Because this is like, when we see patients, whether it's in the United States, India, UK, Canada, Australia, we're Singapore, Malaysia, there's South Asians everywhere, right? We're 25% of the world's population. There is a real phenomenon going on here, and we need to help our patients get on medications because they're developing severe complications and ending up in surgery, and they're refusing medication. I think Sharon Mother and I realized what was going on, and we decided then to partner with a number of clinicians, not
Right.
just GIs, but surgeons, dietitians, psychologists, physical therapists, you name it. Anybody who can help get us to the best place possible in terms of patient outcomes. So in July 2021, we formed SAIA. We got nonprofit status within a year. So for the last 4 years, we've been advocating together as a patient and clinician-led initiative, and really developing patient education, doing professional development work for HCPs, healthcare providers to understand the significance of what's going on and to develop that cultural competency. And we started to do research together, patient-led studies, but also, just patient-reviewed papers as well. So I'll let Madhura talk a little bit more about that, but I figured I'd get us started with explaining a little bit about the pillars of SAIA.
Yeah. Madhura, if you can also add on to whatever you say, the priorities of SAIA, right? The top 3 priorities, for instance.
So like Tina said, I think, our real goal is to ensure that every IBD patient has access to the best possible care and is able to get to that best possible care. So our mission really is to create that kind of resources, research, and education that patients need, but also that healthcare providers need, especially providers such as gastroenterologists, like Tina mentioned, the multidisciplinary providers, including psychologists, dietitians, to minimize some of the delays that Tina and I discussed, but also to dispel stigma around bowel conditions and treatment for conditions like IBD, and promote early diagnosis. So we see these as very important aspects through which we can improve patient outcomes. One thing that we've been doing together is to really identify and resolve barriers to patient care. And we come at it both from a patient perspective in terms of what are our challenges, which is where culture becomes so important, and from a clinician perspective as well, in terms of what are the barriers clinicians are perceiving in delivering the best possible care to South Asian patients. So the question of what's the role of culture and how can we address cultural norms, which, they operate not as an individual experience, but rather as a structural condition that's creating these hurdles to access to care. This could be stigma around the bowel itself. It could be stigma around treatments for a bowel condition, which, the first question we all are asked is, and we all ask our providers also, is what can I do in terms of changing my diet before I start a medication, right? So how do we really address some of these cultural myths, cultural norms? One of the things that we do, like Tina said, is to really create community awareness through patient education. Our patient education is led both by patients and clinicians because we want to honor both the expertise that lived experience brings, but also recognize that clinicians bring evidence-based education, and we bridge these two perspectives together to deliver education in a manner that's easier to understand, accessible, and acceptable for patients, caregivers, as well as the larger community in terms of learning about IBD. The second thing that we have found is very important is to address the provider piece of things through our professional development arm, which is really to improve access to culturally informed and empathetic care that recognizes that patients are not just a collection of symptoms, but that we have a role in the societies in which we live in. Our cultures shape the people that we are and the ways in which we access treatment. So this includes CME, continuing medical education programming, other conferences and other programming, again, where we really feature and amplify the patient voice on the same platform as the clinician voice, because there is so much to learn from both perspectives. One of the things that we are also extremely passionate about, and something that we have been doing right from the beginning, is the pursuit of affordable medication. So now I don't want to speak for the US perspective. It would not be appropriate. And I recognize that the US insurance situation is a hellfire of its own. But in India, the cost of IBD treatment is so enormously expensive. Everything is out of pocket, from your doctor visits to your colonoscopies, blood work, monitoring, as well as the medications that we use for IBD, some of which range anywhere between 7,000, 8,000 rupees per single dose to 1 lakh rupees per single dose. This is a completely unaffordable landscape of treatment. It's a landscape of treatment that can lead you to financial toxicity. Simultaneously, not treating this progressive immune-mediated condition can lead you to financial toxicity because of the cost of disability as well. At SAIA, we're very aware of the fact that A, we need more information. So this is where our research arm becomes very relevant. But B, that we need multi-stakeholder collaborations and partnerships to really push the envelope on affordable medication. And this is something that, we are very passionate about and have been doing right from the get-go. And again, where the patient-clinician collaboration becomes so relevant. And finally, of course, like Tina said, research, which is patient-forward, patient-led, focused on improving outcomes, as well as improving representation in clinical research and clinical trials. This is something we are pivoting towards as we grow as an organization, because we recognize that as important as it is for treatment options to be affordable, it is equally important for treatment options to be representative from the drug development phase. So this is broadly where SAIA's different objectives are. Core to our mission and core to all of our efforts is the patient-clinician partnership that I've spoken about, and the idea of this intersection between culture and gastrointestinal health and gastrointestinal care.
Yeah, so many things to unpack there. If I come back to that point of cultural, right, and it is, I think, maybe more so in a South Asian perspective, just the conversations around gastrointestinal and bowels. It's a landmine to start with. How did you kind of leverage that or use that to build the community as well, Tina, right? So if you kind of look at that, was that the point at which people came together, or was that a barrier you had to cross even in your community building? And what worked and what didn't work?
Great question, Aparna. And Madhura, thanks for going over that so beautifully regarding our priorities. With regards to community building, I don't know that it was challenging per se. I would say that it was ripe and ready to be done. It's almost like it's been a problem in South Asia for some time now, let's just say. And when I started my advocacy work in 2018 via Own Your Crohn's, it's just like kind of exploded. And whether it's through Instagram or Facebook, the community came alive. As I was describing, like a Pandora's box, it just kind of opened like a flower, ready to bud. That's what it felt like to me, and it was quite overwhelming. And I noticed that there is significant demand that I alone cannot fulfill. Whether it was through, posts of my personal experience as people got to know me, Aparna, I think what happened is I realized that we really need more consistent resource development and education. And also, I noticed that what the patients are saying anecdotally, the doctors are also saying is a problem, like the medication access or the medication pricing, for instance, in South Asia. But I also noticed that we needed to bring one another together. I believe in unity. I believe in working together and collaborating, whether it's with colleagues like Madhura or with GIs like, on our board, or whether it's with other organizations. And I think community building can only happen through collaboration. This isn't something that I can just do alone or that SAIA can just do alone. We have to keep chipping away together. But I think to open the door, we first have to destigmatize. And destigmatizing the disease, what I did in order to build community, I don't even know if I realized it at the time, to be honest with you, but my sharing of my story, writing blog posts on fistulizing disease, which I didn't even realize in 2019 hadn't really been done from a patient perspective. There wasn't much out there on fistulas. And to date, that's my most read blog post. So many thousands of views because it hit really hard in patients who are really suffering. So I think community building comes through, one, vulnerability and authenticity, sharing parts of yourself that maybe others might not be comfortable with, and that's totally okay. I also think that community building comes through building trust. Once you open yourself up to, a larger audience on social media, and you show parts of yourself that the average individual might not do,
Right.
people come, they're drawn to you. And that's what I learned. I didn't know what I was doing at the time. I was just trying to help the world. But that's what I learned, is that community building happens through vulnerability, authenticity, and then you start building trust. And I
Right.
think that's what we built our IBD Theses community off of, is that vulnerability, authenticity, and then we started building trust. And then some things that we would do, just to give you an example, we had a wonderful GI psychologist who's now on our board, Dr. Tiffany Taft, reach out saying, hey, we have mostly white Caucasians, and specifically women in our, psych studies, GI psych studies around IBD, especially medical trauma, post-traumatic stress. She's like, you just started this community. Can you help me design a survey that can, be more culturally sensitive? And can you distribute this? And I said, absolutely, happy to work with you on this, with no expectation of any kind of authorship. I didn't even know where it was going.
Right.
At the time we were like maybe 2 or 3 months old, and we recruited 70 patients because of that trust in
Right.
just those few months. And they all completed a 15-minute survey. It was published 2 years later in the Indian Journal of Gastroenterology, basically showing that South Asians, Southeast Asians have 5.5 times the rate of post-traumatic stress due to IBD.
Right.
And that's medical trauma, really. That's what I mean by post-traumatic stress, due to IBD as compared to white Caucasians. I mean, that's a significant rate.
Right.
And right now, what we're working on is we have the statistics to show that this is due to cultural stigma. So this is really significant. Not only are we working on things like medication access or pricing, we are also working on research to prove that this is a massive problem and that we need to address and start building interventions around it.
Right.
And
So if you
that
could,
is a form of community building. Sorry. That
right.
is a form of community building, because when the patients start seeing that research come out, they're like, I contributed to that. I contributed to this understanding. And then they
Right.
feel included and they want to be more and more a part of things.
Mhm.
Right. So yeah, I guess again it leads to the next question of mine is, um, you know, there is cultural diversity. So even though it's South Asia is not one homogeneous mix, so there will be diversity across different South Asian identities. Hell, even within India, there are,
Exactly.
different identities. So you have nationalities, you've got language, you've got religion and gender, and I don't know if there are other elements. So, Madhura, can you unpack how that cultural diversity
Yeah.
impacts people living with IPD?
For sure. And Tina, thanks for going into, that community building aspect, because I think we are also learning a lot about the cultural diversity from the community that we are building, and learning from others' experiences just as much as we're sharing our own. And I will also add, before I kind of jump into your question, Aparna, is that the research, yes, makes you feel like you're part of something much larger than yourself and your experience. And it's a very empowering journey, but it's also helping many people get the care that they need. For instance, for me, participating in that survey and participating in that research helped me realize that, wait a second, I have IBD post-traumatic stress, and I'm suffering from post-traumatic stress. I took all of those research papers, including ones that Tina has written with Dr. Taft, and went to my GI, and I was like, I need you to take a look at this, and I need you to tell me how to get the help that I need. And granted, mental health is super stigmatized. It's stigma I have struggled with as well. But I think there's also that element of access to better care through empowerment, through research that exists, and why we do patient-led research. So I just wanted to add that too, because it really did change my life and continues to help me. In terms of cultural diversity, just kind of switching hats and putting on my social sciences hat, thank you for acknowledging first that culture is not monolithic. I think, all conversations have to start from there. We are such
Right.
a massively diverse country and a massively diverse region. And it's also not just a concern of South Asians living in the West, right? Like, lots of times I hear things like, oh, it's a diaspora problem. Cultural stigma is a problem for people like Tina living in the diaspora. We are all Indians. We all get it. No, we don't. I don't know what being Indian means, because my experiences can be so dramatically different from the experiences of somebody who's my neighbor or somebody who's living down the road from me, right? And I think it's very important for us as patient advocates, as healthcare providers also, to recognize that today, the way the region exists, we're actually multiple islands of cultural diversity across the region. And any interventions that we have, any healthcare interactions that we have, must be aware of this diversity. And like you rightly said, it certainly affects access. And in terms of just sketching out the region and regional access, as a patient living in India, while I recognize, what my challenges are in terms of the challenges I've experienced, delays in diagnosis, cost of care, and so on, and finding the right IBD specialist as well. I also recognize that I'm enormously privileged to have IBD specialists in the country, to have access to multiple treatment options that people living in other parts of the region don't have access to. This is just the fact of the matter. This is how things stand today.
Right.
For many individuals who are living in, say, Bhutan, Nepal, Bangladesh, they're traveling into India for their care. And this means you're not just traveling across cities, which many of us in India have to do. You're traveling across countries, you're traveling across cultures, you're meeting healthcare providers who may not speak your language, who may not share a common cultural context, who may not get your challenges in your country. And it is an experience that adds an additional layer of burden that a patient is carrying, right? And just as one of the examples that we have also seen is the question of, say, Ramadan. Can IBD patients fast around Ramadan? This is a constant question that we get. It's something we've built a lot of education around. And I don't think this is a question just because you're an Indian provider or you're a Pakistani provider, you have an easy answer to. And this is where it's important to be cognizant of the fact that culture may play a part in the questions that you ask as a patient to your provider. Can I even ask about fasting? Equally, it shapes the answers that you're able to give as a provider. Should I be telling my patient to fast during Ramadan? And this, I think, is something, this kind of structural condition is important to pay attention to. And I think Tina's gone into this very, beautifully in terms of talking about what are the different challenges that our patients have faced in terms of the stigma around IBD being a diet and lifestyle disease, stigma around treatments, stigma around ostomy surgery, and all of this. Sometimes we tend to treat it as the patient is lost to follow up, or the patient is not being compliant. Why can't these people take their medicines? We don't realize that the lack of compliance is often due to a lot of cultural pressures, cultural factors that are preventing patients from seeking care, that are preventing patients from staying on care. And this is why I think it's so important for us, even though we're all Indian, to discuss the fact that culture matters and culture means different things to different people. Totally agree about gender. And I would also add sexual orientation and caste as two other axes for us to be aware of as South Asians, along which, we see cultural considerations of care play out. I think in terms of gender, there's so much research about micronutrient deficiencies, malnutrition, simply because of the eating order in the house, right? Who's the first person to eat? Who's eating the leftovers? Whose preferences is the household catering to?
Right.
And it makes a huge difference, right? In terms of what are the kinds of even nutrition that you're getting, forget treatment options. And of course, massive disparities around healthcare spending as well, both along gender and caste axes that have been well documented. I will also add from my own experience, there's a lack of adequate guidance on reproductive health. So as for both IBD patients as well as, both IBD providers as well as gynecologists, how do we manage pregnancy in IBD patients? Amazing research that's happening around this in the US, led by Dr. Uma Mahadevan, but it needs to translate to our providers and our patients so we can advocate for this. From the LGBTQIA piece, and I'll stop there because I recognize I'm going into a lot of detail here.
No, it's okay. You can go ahead.
Okay, it's something I experience as well. So I identify as a member of the LGBTQIA community, and this is again one of those things that we simply don't talk about because we think it doesn't exist. How do we think about everyday healthcare discrimination, right? For instance, providers who believe it doesn't matter if you're straight or not, I'm going to treat you the same. No, it matters because you're doing a colonoscopy. You're having access to the most intimate parts of my life. It matters because it shapes my decisions around how I want to lead a life. what vaccines I might need. What, for instance, can I have anal receptive intercourse? And that's a key area where vaccines and anal receptive intercourse are two top areas where you see that direct interaction between IBD and LGBTQI considerations, right? And of course, there's the larger concern of I'm navigating stigma because of my identity and because of my chronic illness. How do I live with these additional burdens? True for the gender aspect of things as well. Sometimes we see male patients who say their wives help them with their ostomies, but we hear from women patients that they're being beaten or they're being abandoned in hospitals by their family members. So I think these are elements for us to be aware of. It's not immediately apparent when you think about IBD as just a bowel condition and a collection of symptoms, but really we deal with so much more, and so much more affects our participation in the healthcare system as well.
Right.
If you don't mind me adding, Madhura, that was fantastic. I think sometimes, like when we're thinking about a condition, we often don't think about the psychosocial elements. But in addition to the psychosocial elements, there's a cultural axis. And that cultural axis is so significant in our community. We have so many different religions, so many different cultures, traditions, so many different festivals, and one community might celebrate it and the other might not. I'm going to give you just a very quick example because I think this is such an important point. If any of you have read Chetan Bhagat's Two States, they're sort of showing a couple, a North-South couple, Tamilian and Punjabi. One of my friends gifted me that book on my wedding day because I'm married to a man who's of Kannadiga descent and I'm Sindhi. And it was like light bulbs were going off when I read that book because the cultural differences, and I noticed it while I was dating him, are so significant. You have to learn a whole other culture. It's like, it's like marrying into another community, even though we're both the same religion. And it felt like I was marrying somebody from another country. I was used to Sindhi folks, Punjabi, Gujarati. Yes, there's similarities, there's differences there, but this was a whole other world, the North-South differences. I think I just want to use that as an example of what Madhura is talking about. If a provider in the South doesn't understand the eating habits of somebody in the North or the religion or their traditions or cultural practices, how can they opine on that without the cultural competency?
Yeah. No, and I think that's, and you don't even have to be north-south, right? As Madhura
exactly.
said, go down the road or
exactly
go to a different community within the same town or
100%.
Yeah. So I think in an Indian context, sometimes 20 kilometers makes a difference. So so I think it's and to your point, right? You use the example of Ramadan, and again, so if you look at it from the they do have exemptions for people who are unwell, but there is a lot of guilt and trauma that typically people feel if they're not able to observe Ramadan. So and this has come up in our conversations with people from that community as well. So while you're dealing with all this, while you're trying to so how does this affect the roles you address as a patient advocacy group, right? And both towards the community as well as towards the providers?
I think, to my mind, as patients, like Tina said in her introduction, right? Like she's a wife, she's a daughter, she's a sister. We all play those roles. We all have expectations from our families, taking care of the family, marriageability, pregnancy, fertility, whatever, the pressure to be the perfect child, perfect spouse, perfect parent. And I think, and this has been something that I feel strongly personally, but I also think this informs SAIA's work. The role of medical care is really to enable each of us as patients to get to a place where we can perform the roles that we want to perform. And I think the role of our advocacy work is to ensure that we're free from chains of misinformation, the shame and the stigma that makes us seem less capable in the eyes of the world. And Tina, to borrow from your blog, because I remember reading this several years ago when somebody had made this column saying, should I dump this man because he has a disability or something? It's, this is such a prevalent and problematic construction that exists in the world around us. It's so important for us as advocates really to address this and to remember that we are not less capable just because the world around us is not built for us, right? Our role as patient advocates and patient advocacy groups is really to create those enabling conditions to grow. And for me, as a starting point, it's really to seek that common ground. And this is something we navigate at SAIA. I'm not going to say this is easy, but it is something that all of us patients and providers at SAIA are committed to, which is to really find that common ground and ask questions rather than assume, and understand both from a patient and clinician perspective, what are all the burdens that we are experiencing? What are the gaps they are not aware of that we can help fill? And how is it that we can create those conditions for better informed care? And how can we help patients feel empowered in and of themselves to seek out better care? Sometimes a prior bad experience or even the bad experience of somebody who's an older person in your family is enough to stop you from seeking care, right? And we really want to address these intergenerational challenges that patients are facing also. And one thing that we build our advocacy platform around and we build SAIA around is the notion of empathy and empathetic conversation, which includes being alive to the fact that as patients, Tina and I and Sharon have expertise built off of the suffering and pain we have gone through. And our cultural context, you may not be aware of, but we are the experts of our own cultural context. And how can we help healthcare providers hear this? And to the credit of our healthcare providers, they are able to come to the platform, they're able to come to the plate and say, help us understand so that we can educate our peers. This is something that I think sets SAIA apart, and it makes me very grateful to work with the providers that we have. And ultimately, I think at SAIA, something that we're committed to is the idea of patient dignity and patient agency. We want patients to feel like they are partners in care, not that they're subjects of care or they're passive recipients of care. And we want patients to enter a situation feeling dignified, feeling confident, and feeling empowered. Like Tina said, we can't do it all. Tina or me or Sharon or anybody in our team, we cannot be those people that save the world, right? That help everybody access care. Our role is as kind of almost guide patients to the right resources, the right providers, guide providers to the right resources as well, to ensure that that final patient-provider interaction is dignified, it's respectful, and it's recognizing that cultural cognizance and cultural respect is the starting foundation to build that relationship of trust that Tina was talking about too.
Thank you. Thank you, Madhura. I think you've kind of articulated it extremely well. Taking a kind of switching gears a little bit, Tina, you're talked of research being a key pillar of your work. Can you share some of the work you're doing, in the space of research as patient advocates? And I know you've touched on a few on them, but if there's a couple that you want to highlight.
Sounds great, Aparna. So this is a really important topic to us. For one, we've done a couple of systematic reviews, form of research, looking at to prove the point that many races and ethnicities, cultures, and even people of different sexual orientations and gender identities often do not participate in clinical trials. So we have a couple of systematic reviews out there proving that point. And the point of research really is so that we can start moving the needle and start developing interventions for changing that. So in the Lancet, in gastroenterology, in various acclaimed journals, we have published this and done significant research on this. And since we have set the stage for it, now we're developing, ways to develop interventions and make sure we can increase trial participation, not just trial participation, really research participation within our community. So something that we came up with for an initiative this year was setting up a clinical research roundtable. And what we did, this was in Digestive Disease Week in San Diego, we had several patients of various origins, mostly South Asian, but we had some that were Middle Eastern, North African, as well as one that was a Pacific Islander and one from East Asia. Sort of to show that, Asians are not a monolith either, and that there's so many cultures, traditions, religions, and such diversity, and that Asians are really 60% of the world's population. And if we're not including them, we're doing a disservice not only to Asians, but to research as a whole and to the disease and patient outcomes as a whole. So we brought together a roundtable of, I believe, 11 patients, including myself, and 13, 14 physicians from around the world, US, Canada, UK, India, Pakistan, even UAE, different parts of the world, really to help have this moderated conversation about what are your barriers. And what Madhura and I did prior to that roundtable is we took sessions explaining how trials work, explaining how research works, so that we can empower the patient advocates that we had, that our board had chosen to bring to this event. And what we did with that was basically start to develop an understanding of the barriers so that we can start to propose solutions. We have a paper now that we're awaiting publication on this. And I think this has helped to now set the stage for, okay, we understand the barriers from the patient's mouth itself. They are similar in the Asian community, not the same, but very similar. And I want to just, emphasize one point. In the United States, for instance, there's often understanding around the Black, Hispanic, Native American communities, Red Indian communities, that that they have historically not been represented, and there's been abuses of the system, unfortunately, and that they haven't necessarily been treated well, and therefore they don't have the trust to join research. Well, this is the first roundtable to sort of prove that colonialism bred distrust across Asian communities and has led to a lack of participation in research. Now, I'm going to leave a little bit of a surprise element here of what are some of the solutions we're proposing, but we are trying to step by step set the stage so that we can develop interventions to organically start creating more participation in research. And to keep building trust in the community, developing patient representation from different communities, and also showcasing that this is a broader problem than people realize. So that is one of the things that we're doing in terms of clinical trials. There's a lot more to come, and you'll see over the coming years how that sort of sprouts and develops.
Thank you, Tina. So I think we've talked of research, we've talked of cultural, kind of differences, we've talked of community building. Tina, you touched on it as to where you see differences in terms of what was happening in the US or in the Western world, and how you're advocating for South Asians to be included and recognize those cultural differences as well. Given where we are in South Asia in general in terms of patient engagement and advocacy, and your experience as an advocate in the US, how do you translate your experience and learnings in the work you're doing at SAIA, and where do you see the biggest challenge that you need to bridge?
In terms of advocacy, I think in Asia in general, from what I have noticed, and also from various conversations I've had with physicians, with industry, psychologists, etc., in Asia, patient advocacy still appears to be in its nascency. I think, and I'm not throwing shade in any type of way, I think that there still needs to be an acceptance of patients as partners when it comes to sharing their lived experiences at conferences, or when it comes to saying, okay, patients aren't equal. We need to value their lived experience as a patient-reported outcome to see what is it that we can do differently to improve care. There are still hierarchies, and it's totally understandable. These things take time to start to chip at and break down. But we do see that difference, I would say, Aparna, and I'm sure you're probably seeing it as well, working in Asia. It's one of the things that I think Europe is slightly more advanced than the United States. United States is catching up a bit to Europe, and Asia is right behind the US. So it is definitely an evolution that I'm seeing. But I think with advocates as brilliant as someone like Madhura and yourself, Aparna, things can really start to change. We are really starting to chip away at telling industry they absolutely need to bring trials to the region. They absolutely need to activate and empower patient advocates in the region. Good, strong patient advocates that can really represent what the phenomenon is in their countries to really start, changing the paradigm on not just patients as an equal participant in care and research, et cetera, but also starting to really understand, how do we get to that medication access? How do we develop programs for patients to afford medications better? Patients can opine on this. There's many brilliant patients out there. It's a matter of finding them, activating them, empowering them. And I still think we have a ways to go in Asia, but I am thrilled to be working with patients like Madhura, advocates like yourselves. And also, we are seeing more and more patients just from the work that SAIA is doing, saying, hey, I want to be a part of this. Hey, I see a real change, a phenomenon, a movement happening, and I also want to do this. We are seeing a lot of that in the last couple of years. And I think as more and more patient advocacy groups come up that have this vision to empower more patients, we can get there.
No, absolutely. And I think, one of the things which we often, while we still don't acknowledge enough is the value of lived experience, right? We're still bridging the gap in Asia of that just being seen as an anecdote versus actually valuable expertise. So it's changing though. And again, I think I'm hopeful and we'll keep chipping away at it, as you said. Madhura, what do you think are the factors that have contributed to SAIA's success as a PAG?
So, Tina, I loved how you put it. So I'm just going to quote you. I think the three things that SAIA is most committed to is vulnerability, authenticity, and trust. I think we are committed to being as authentic as possible about our stories when we talk about them. So we have advocates from other Asian regions, like Tina mentioned, including from Southwest Asia and North Africa, the Middle East, that is, who share their experiences, their considerations, their concerns. And we do it while protecting our patients. We don't want anybody to feel any kind of repercussion from sharing their stories. We have safety networks put in place. And trust, I think, is the only way to run a patient-clinician collaborative. And I think Tina leads us so successfully, along with the chair of our board, Dr. Nandi, as well as our board of directors, where we've built this relationship of trust between the patients and the clinicians to ensure that we are all on the same page of wanting to improve patient outcomes. So I think truly, if you ask me, that really is what contributes to our success as a patient advocacy group.
Thank you. And Tina, if you were to think about what the mistakes that SAIA has made that you have learned from, or that you would want other patient groups to not make.
I think that's a fantastic question, Aparna. I never look at anything as a mistake. I always try to make sure that I keep a very positive mindset and realistic at the same time. For me, I think they're learning experiences and sort of steps to growth. For me, I think learning it has been more about seeing what works for the community, what doesn't work for the community. Um, I am going to give an example of something that we learned a lot from. We were doing a session with a doctor that we often work with, Dr. Aline Charabati, on Monday Night IBD. It's a Twitter platform. And she wanted the patient experience. And we were like, you know what? Let's poll our community and see what they think. And we learned very quickly in that polling that many people didn't realize they were facing stigma, and that many people didn't realize how internalized the stigma was.
Wow.
So we took a step back and we're like, okay, there's something going on over here. And I was like, Mother and I and Sharon, we were like, let's describe the stigma. Okay, let's describe aspects of the stigma. And like almost everyone checked it off. And the broader point of what I'm making is they were experiencing it, they didn't have the vocabulary for it.
Right.
Oftentimes it takes a lot of introspection to get to that vocabulary. It did for me. Cultural stigma, internalized stigma were not terms I learned until I went through a lot of therapy with my mental health counselor. And then I realized what it was I was experiencing. So it dawned on me what was going on. And in that polling, so then we expanded sort of the definition of stigma, and everyone came in and pretty much said, yes, they were.
Right.
And I think that's a broader picture that we got is, oh my God, anecdotally, almost all of these people are experiencing this, that they don't know it. And that gave us the basis for how to also approach future education, future surveys, future even professional development events, because we were like, if the patients are experiencing this, the doctors might also be experiencing this. I remember I was told before my diagnosis by a South Asian GP, general practitioner, South Asians don't get IBD. South Asians don't get colorectal cancer. You don't need a colonoscopy.
Right.
And also we've heard from South Asian providers, oh, no, biologics, that's a treatment option for IBD, a class of drugs. Monoclonal antibodies. Oh, no. We'd rather keep you on, something we've known about for many years. Oh, no. That's an infusion injection. Unfortunately, our community of physicians sometimes experience stigma, internalized, and oftentimes our patients do too, and their families do too, and they don't recognize what that phenomenon is. And I think we have since learned from that, that we need to approach stigma in a way that's broader and define examples of it. So I think I really like to look at these as learning experiences so that we can keep stepping up our growth and keep expanding and keep making sure we're meeting the community's needs.
So on stigma, actually, one of the most insightful comments I had from one of the patients we were speaking to was that he said, look, I didn't know anything about the condition, and it's not IBD, it's a different condition. I didn't know anything about the condition, but it was the way the doctor told me once I was diagnosed with it. And then he asked me a whole bunch of intrusive questions that actually created the stigma. Till then, it was just a condition that I hadn't even heard of, but that stigma kind of was through the HCP. And then we've kind of tested that with a few other conditions and a few other patients, and we find that is actually fairly common.
Yeah, I would agree with you, Aparna. Like, I woke up from having a feeding tube, and my first reaction was, why is it 50 feet long? But the nurses around me were flipping out. They all were concerned that I had cancer and I was, terminally ill. And that's why I had a feeding tube. And of course, I looked the part because I was so malnourished. And I'm just sitting there wondering, I'm joking about it and telling my GI I need a plumber. What have you put in my body? And, the people around me are so freaked out by it. And you're right. Sometimes those interactions, as well-meaning as they might be the sources that are actually increasing the stigma for the patient and their caregiver as well.
Yeah. So, Madhura, you've gone for the last few years into patient advocacy, and I'm sure you follow other initiatives as well. Is there an effort that inspired you, or you want to know more about?
Okay,
And
I'm not brown nosing here, but both of you were very important sources for me to get into patient advocacy, both Tina and her blog. Onyo Crohn's, like I was 24 when I was diagnosed, and Tina was writing about being 24 and needing ostomy surgery, and how it changed her career from Wall Street to suddenly being disabled. And it really hit home for me. And similarly with you, Aparna, I think the first phone call that we took to talk about my feeding tube and sharing my story suddenly made me aware of a different way of doing advocacy, which is very respectful of patient boundaries, respectful of how a patient might want to talk about their condition, rather than saying sharing patient stories is the only way to do advocacy, right? And for me, both of you really made a huge difference. So I just want to say thank you for the work that both of you do, and for the amount of effort and selfless service that goes into running your organizations. I know it firsthand now. The IBD space has a tremendous number of amazing organizations that are working there, including the Crohn's and Colitis Foundation, Nutritional Therapy for IBD, Girls with Guts, IBD moms. There are a series of patient advocates as well. Gutless and Glamorous is one person that, comes off the top of my head, as well as a whole bunch of others, including the amazing patient advocates who serve on our team as well. And I think from an Indian perspective, because when I was starting out, I didn't find anybody in the IBD space from India, and that unfortunately continues to be the case. I think SAIA has emerged as one of the key players here. But I think there's a lot for us to learn from rare disease organizations. So ORDI and Mr. Prasanna Shirol, the amazing work that he has done, and he's such a wonderful person to talk to, is one person that, I look up to a lot as well. And similarly, Indo-US Rare also doing some amazing work in their spaces. There is a newer organization called Believing in the Invisible, which is run by a series of patient advocates, including Anjali Vyas. And they're a newer organization that I'm also enjoying following and learning about, because I think this idea of invisible disabilities is something that's catching more prominence now in India. And I think it's interesting to see the work that they're doing to destigmatize the invisible aspect of living with some of these chronic conditions.
Thank you, Madhura. And thank you for,
of course,
saying such nice things about us. So, and any final comments from you, Madhura, before I ask Tina for her
thank you for
advice?
having us, Aparna. And I think I really enjoy speaking with other patient advocates and finding ways for us to learn and work together. And I love the title of your series as well, Lived and Leading. Thank you for platforming patient expertise and treating lived experience, like you said, not as anecdote, but really as expertise. I think we together can move a lot of things in this space.
Thank you, Madhura. Tina, again, because you bring these multiple perspectives, a word for other aspiring patient advocates, especially from Asia, and your closing comments.
First of all, this was fantastic. I'm so glad we got to do this together, Aparna, and I hope we can keep collaborating in the future. Really important to continue to highlight more and more patient advocacy groups and the expertise of other patients as well. Just a few words for aspiring patient advocates. I really meant it when I said vulnerability, authenticity, and trust. There is a real role and responsibility for patient advocates in this space. I often felt like in the beginning that this was social suicide coming out with my IBD and with my ostomy, because so many family friends and family members were just like, what are you doing? You're going to ruin your family's reputation in society, affect your sister's marriageability, all this jazz, whatever. And it was really hard for me. I kept debating, do I just want to go back under the covers and, is this worth it? Is this exposure worth it? But I will say that it is worth it. If you really, truly want meaning, purpose, want to do the right thing, for a community that's really struggling and often unheard and underrepresented, it's important to keep speaking up. It's important to not just share your story, but share the stories of others, and to help build others up as well. I think there is a real responsibility of, performing our SAIA, our selfless service. I look at it as, individuals who can lead with a positive attitude and put positivity out there. There's a lot of negativity when you're dealing with illness, and it's really important to see the light at the end of the tunnel and how you can empower yourself and empower others at the same time.
Right. And any other closing comments, or that concludes your closing comments as well?
I just wanted to say thank you for the opportunity to highlight the work our team at SAIA is doing. We are very grateful, and that we hope to keep growing and expanding our relationships in Asia and globally. I think there's a real need as IBD continues to grow at tremendous rates in India, but across South Asia and all over the world, really. There will be continued unmet needs, and I think it's important for us to continue to join hands and really help the community and meet the community where they're at to help rebuild any kind of resilience in them.
Thank you. Thank you, Tina, and thank you, Madhura. I think really the reason we started this is to showcase the work of patient advocates as well as patient advocacy groups, right? Because Patients Engage, I firmly believe that, people who live with chronic conditions are managing over 90%, almost 95% of care outside the clinical arena. And if we don't understand what goes on in those lives of theirs, there is no way you can create systems that will improve patient outcomes. We talk of information asymmetry from a perspective of patients not knowing enough about the disease. But I've now come to acknowledge and state that actually the information asymmetry is both ways, right? The healthcare system and the providers don't understand what's happening in the lives of patients and what is impacting decisions that they are making. So I think it's important for us to showcase and to understand and to represent that community as patient advocates. And that's the role that patient advocacy groups play in improving the quality of healthcare design. And, that's something that is important that we continue to do. And as you said rightly, as both of you said, that we need to collaborate across communities, across disease groups, across geographies, because at the end of the day, as you said, South Asia is 25%, Asia is 60%, and if anybody calls themselves a global organization, how can they not listen to the voices of these communities, right? So I think thank you so much, Tina and Madhura, for taking time on a weekend to share your experiences as well as the work that, the incredible work that you're doing at SAIA, locally, globally, etc. So more power to you, and look forward to continuing to collaborate together so that we can improve lives of patients out there with chronic conditions and IBD specifically in this case. So thank you so much.
Thank you so much.
Thank you.
Take care.